Hello, everyone. It's Dr. Kathleen O'Neill Smith here. How are you doing? This is a different type of town hall than we had the last time. So last time we had everybody was visible, it was more like a Zoom. And right now we're going to have more of a webinar because there may potentially be more people. And hopefully there will be. And if there's not, no worries. We'll take care of the people who were able to show up today. Let's get started. But I want to use the same record speed to go through uh, this particular presentation, the go-to guide, 81 days and counting, as the medical and academic community have been working as a team to get through what they could learn about COVID in a very short time. This is absolutely positively unprecedented, and we will never see anything like this. Teams of people coming together to do the job, to get the job done, and it's really amazing. So I've been keeping up as much as I can with all of the data, all of the studies, all of the science, and really trying to um, obtain as much information as I can to take care of you guys, to take care of myself, to take care of my family and my loved ones, and also to take care of all of you. And that's what I care about. And you all of you who know me know that. So we're going to try to go through this in record time. But we've had one before with just some basics back in late March, early April. And now this is a follow up with all of the new things that we've learned. So in Massachusetts today, there's a total of about 88,000 cases. And I don't know how they're measuring this because how they measure things is really always the important thing. But there are about 27 or 28,000 recovered cases of COVID as well, and about 6,000 deaths, and presently 2,500 as of today hospitalized. That's a lot because the big hospitals in Boston, like the Mass General and the BI and the Brigham, have about 800 beds. So those are the three big hospitals around. And if they have 800 beds, that's 2,400 beds. They are full to the brim with COVID patients. So the state has done an outstanding job. I absolutely applaud the job that they have done. I'm totally impressed at the way that Massachusetts has handled this and I handled this pandemic. And I really believe that we had some of the first cases here back in early March with the Biogen conference. And I really believe that everybody just, stepped up and took on the role that they could take on as part of the team to make everything better here. So we'll basically move around. One of the key things about this has been, asymptomatic people spread this virus. So 40 to 50% of the transmission is shed during 5 days when nobody knows that they have it. So that makes it a little bit tricky. And the data also suggests that 20% of infected people, 20%, a mere 20%, are responsible for 99% of the viral load that gets released into the environment and infects others. That's pretty amazing. And the hopeful thing I think that's really cool about it now being May 20th, and we're getting into the long days of summer and the summer solstice, in all countries that have done really good contact tracing, there's only been a single outbreak reported from an outdoor event. That is amazing. Now, we don't know that all events are reported, but of all that have been reported, which is a lot, this is worldwide, there's only been one event that has been reported from an outdoor event. So it's time for us to get outside and get back to life. And we're going to talk a little bit about that coming up. So I want you to, this is really for you, and I want to have a minimum of 20, like maybe 30 minutes for your questions. I'd like you to type your questions in the chat room as we go through the slides, because I'm not really going to give anyone the floor because we're going to move through all these questions that you have quickly. I may not answer them, and I hope I can, but if I don't, I definitely want to have them in the chat room. So, and have them identified in this chat room so I can come back to them at another town hall if we need it. And thank you for your questions in advance. So we're just going to look at we're not going to go backwards. We're not going to look at the things everybody knows about. We're going to look at some of the current information, some of the things that are new on COVID-19. We are going to talk about prevention and immune resilience. It's critically important because we don't have a vaccine. And if we don't have a vaccine and we don't have any treatment, we have nothing on the horizon and we have nothing prophylactically as a preventative medication, then we've got to be thinking about how are we going to do prevention and what is the best way that we can optimize that. We also want to talk about the testing, what type of testing is available, and clarify some of the questions around that. This is an evolving science, and it's really important to understand that. My partner here, Dr. Angeli Akey, with the two of us, with a team of unbelievably dedicated, passionate young people, have put together a resource basically for all of you, and that will be updated as emerging data comes out for you to look at and to understand the basics of COVID and your body and how you can be preventative within your own daily life. So Dr. Akey, I will introduce her in a little bit. She doesn't have, we didn't get on early enough and get this all set up, but she is an internal medicine doctor as well and an integrative medicine doctor. And she's in Florida, located in Gainesville, and she's been in clinical practice for 27 years. And she does a lot of conventional medicine, some regenerative medicine, some oriental medicine. She studied and taught at the Florida School of Acupuncture and Oriental Medicine. So she has a very broad foundation as well. And it's been wonderful to work with her and to share our insight and our views on all kinds of diseases and all kinds of processes that cause diseases. She was the youngest person ever admitted to the University of Florida College of Medicine many years ago. And she ultimately did her training and worked as an assistant clinical professor at Yale University in New Haven, which you all know of. She and I speak together at international conferences and national medical conferences. She's spoken in the Dominican Republic, Brazil, Poland, Spain, Italy, France, and all over the United States as well. So both she and I have a passion for educating the public, for educating consumers, for making sure that you've got appropriate information in your toolkit, in your little doctor's kit at home so that you know how to keep yourself well. And we have, over the last 2 years, partnered together to form the Fire 'em Up Doctors. And you see that at the bottom of the screen here, FIRRIM, Fire 'em Up Doctors, functional, integrative, restorative, regenerative, internal medicine doctors. And we really want to help people take control of their health. So that's one of the things that we care a lot about. So I'll introduce Dr. Akey in the end after we get through a few things, and certainly answer your questions because we'll introduce the book that we wrote. There have been some new manifestations of COVID, and certainly what we've learned is that COVID is unique in terms of the pneumonia spectrum. It is not the same as SARS. It's very different. The clotting mechanisms and the cardiovascular components and the overreactive inflammatory system and the cytokine storm are all really unique to COVID-19. So it's taken doctors to get a little bit of time to get up to speed with what these manifestations are and how are we going to deal with them. We are 80 days into this. That is nothing in the scheme of here in the United States. And we know that Italy was bombarded and really, I'm sure, with so many cases per 100,000 people, they really had a difficult time getting up to speed. They were caught blindfolded. We were not caught nearly as blindfolded. There are other unique nervous system manifestations, but I would still call them cardiovascular, like stroke and ataxia, and those definitely have a vascular component. The loss of smell, which is called anosmia, and the loss of taste, ageusia, are also unique manifestations that are related to the nervous system, the central nerves. So really interesting. The loss of smell can happen pretty early on in the course of an illness and then can last for a month or 2 months. But generally speaking, we're hopeful that it will come back in most people. It is usually one of the first cranial nerves that can take a hit when something in the external environment is impacting the body. So it's not uncommon generally, but it is uncommon in these coronaviruses. Some of the unique skin manifestations have also been interesting, including the recent unique skin manifestation in children, which is very serious, the Kawasaki-like syndrome, where the children have rashes and then end up with some inflammation within their blood vessels or their vascular system. Very, very serious. And we've also recently, within the last 1 to 2 weeks, heard about the COVID toes. And so these are all really, really new manifestations. And we're going to continue to see manifestations pop up as we have more and more cases. And one of the concerns that makes this talk even more important that physicians have is that we're worried that if someone has had COVID symptomatically or asymptomatically been infected, it may impact some of the other comorbidities that they have. If someone has an autoimmune condition, anything like an MS or a type 1 diabetes or a rheumatoid arthritis or any of the myriad of autoimmune conditions, including undefined connective tissue disorder, then those people we have to follow closely subsequent to this COVID pandemic, because we are not sure how even being exposed to this, whether you get sick or not, whether you're just asymptomatic and develop antibodies or don't get a full-blown illness, we want to understand how that will manifest in your body in other ways as a delayed reaction. So it's really important for us to understand this. But new information will continue to be gathered, and Dr. Akey and I are going to continue to update the living resource that we've put together for the instructional guide for COVID-19. Now, this is a really important slide. I'm going to spend a minute with it. And I love diagrams and pictures, and it gets overwhelming, but I'm going to try to simplify this for you. And the key thing about this is it starts at day 1 on the x-axis, and then it talks about illness on the y-axis. And basically, you can see here before the first dotted line, between day 1 and day 5, that essentially that's the incubation period. And there's a certain amount of the virus right here, but over the first 5 days, that begins to go up. And people have the highest viral load here at the peak of that viral replication blue diamond. That's where people end up with the peak of the virus in their system, but they're shedding it from day 0 or day 1 all the way to day 5 or day 7 asymptomatically. That's what we call a prodrome. That's what we call an incubation period. Now, this is a diagram that we added in our book, and we explain it in detail. So I'm going to do a brief explanation here. During the most important thing is to look at, when we're looking at this viral replication, is a person's innate immunity. So you've got to think, if you have been constantly barraged by inflammation or other problems, and your immune system has been barraged, the immediate immune response or the innate immunity that you have is going to be a little weakened. And that's what will allow you to allow this virus to replicate at higher rates and potentially affect you. And also, you have a higher viral load, you can shed that viral load and infect many other people. So the innate immunity is more the mucosal immunity. It's the immunity of the hairs in our nose and the mucus in our nose and the mucus in our throat when we cough and clear our throat constantly. Innate immunity involves all of those things that are outside of the body that does not want to allow the bug to get into the body, or a pathogen or a chemical into the body. That's why we have this innate immunity that's really right there in the mucosa. It's our mucosal immunity with some secretory antibodies like secretory IgA or SIgA and secretory IgM that basically is there ready to prevent anything from even gaining entry into your system. Now, if things gain entry into our system, we have our adaptive immunity down the bottom that will take over from this innate immunity. And the innate immunity is fighting the war against this pathogen between the time it begins to make you sick, this symptomatic period between the 2 dotted lines at day 5 and day 11, the innate immunity is fighting that. It will continue to fight as much as it can all the way through the infection if you get infected and become symptomatic. And even if you are asymptomatic, it may be what prevents you from getting a full-blown symptom, 14-day or 28-day symptoms from COVID would be potentially your innate immunity. The innate immunity is like the National Guard. By day 7, it's trying to hand over to a whole other group of immune complexes that are systemic. They're inside the body. They're circulating in the blood, and we'll talk about that a little bit more. That's called the adaptive immunity by the time we get out to the 3rd dotted line from day 11 to day 14. The adaptive immunity inside the body that's adapting to the things that are coming in from the outside world, it's adapting very rapidly. The National Guard comes out, and then the SWAT team comes in from all over the country and adapts to what the National Guard was able to do, and then continues the battle and tries to shut off this whole infection process. Now, the key thing that we see over here, if you get really, really sick and you end up hospitalized and you become hypoxic and have difficulty breathing, is we get this T cell activation. It's an overactivation and an imbalance in this adaptive immune system response. And basically, you can end up with that cytokine storm. And we'll talk a little bit about that as we go along in this slide deck. But compared with the prior teaching that I did in early April, late March, I said then that about 85% of people, of 100% of the population, if you take 100% of the population, 85% would be mildly symptomatic or asymptomatic, and that 15% would end up in the hospital, and that 5% might end up in an ICU. That's different now. So, 60 days later, we now believe that 99% of the population will either have mild symptoms and be able to recover at home if they get sick during this 5-day window to 28 days. They may need Tylenol, they may need something else, but they will be able to recover at home. And it will be about 1% that will be hospitalized, and it'll be less than 1% in the 0.5% range of people who will not make it and not survive. And that's a really different story and a much more hopeful story. So we really do need to be thinking about immune resilience if we are going to successfully, get back into the world and not be worried about becoming infected and what could happen to us, and would there be enough hospital beds. The important thing to think about this immune resilience is when we think about COVID-19, we're thinking about viral load. We're thinking about exposure to the virus, which is going to be silent. You're not even going to know that you've got exposure to the virus most of the time. And what we have to understand is how much is that viral load, and how long have we been exposed? What's the duration of exposure to the virus in that setting? So the number of virus particles is really important and really necessary to understand and in order to determine the course of this infection. But we can create better barriers, we can have better immune resilience, and we really need to address that because there is no prophylaxis, as we said previously. Well, let's go to the next slide. So the risk factors in 90% of people who die have to do with pre-existing conditions. So these are things that are hard to change. They're not going to change in a day, a week, a month, 3 months. You're not going to get rid of your diabetes type 2, or certainly not type 1. You're not going to get rid of your cardiovascular disease, particularly if you've already had a procedure. It's really hard to get rid of high blood pressure or hypertension. And obesity, I don't think people really, obesity is really, really hard to change. So we've got to really be thinking about some of the other things that we can absolutely impact. So in order to decrease viral exposure, we've got to be thinking about being indoors, the indoor density, the number of people per square foot. If you have a small space, like my office space that many of you have been into, it's not very big. If I sit in there with 4 people and we stay there for an hour, that's not a good situation. If I sit in there with 1 person and we stay in there for 15 minutes, that won't be so bad, especially if we're 6 feet apart. If we add masks to that, each person, 2 people in my little office, tiny square footage, 2 people, and neither of us is coughing or sneezing or singing, we could be singing, or breathing or talking too effusively as I am now. If we have masks on, we're not going to basically aerosolize virus or shed virus as much, and we will be more protected. So the indoor occupation density, the number of people in a particular square footage, is really important. If there are more people per square foot, it is a hotspot. You've got to know that. So any work situation with high numbers of people, regardless of wearing masks, we've got to understand that that could be a hotspot. So that's really, really important. The viral load can be bigger. We really can't change nursing homes, and many of the deaths in each of the states and each of the counties is really related to nursing homes. I mean, these people are in that setting. They can't leave. There's all kinds of people coming and going, and that's why they had to limit the number of people visiting nursing homes in order to limit the spread of COVID-19. Now, the immune system age is something that we can change. It's really, really adaptable. We can change this absolutely. It depends on your lifestyle, the food you eat, the way you sleep, getting adequate sleep, the way you move, moving every day. It doesn't have to be intensive exercise, but movement is important, and the way your body handle stress or the way you feel stress. So meditation and breathing and downtime and rest time is really, really important. The last thing is immune barrier health, and this would be more where a clinician would come in, a regenerative clinician like myself or Dr. Akey, and we would help you understand what is your immune barrier health. How is your mucosal, how healthy is your mucosal immunity? How healthy is your systemic inside your body, your internal immunity? Do you have a permeability in that one cell layer thickness that interfaces between the outside world and the inside world? And if you do, how do we help you change it? So it's really, really important that we help you understand how to improve your antibodies, how to improve your natural killer cells so that we can help you to be one of the people who does not get sick with COVID-19 and who becomes immune to that. So this is a study in April done in New York City where they looked at 3,300 patients who were positive for COVID. And they saw that age was a really important risk factor, but it's not really only your chronological age. You know, if you're 60, you could be really fit, really well, and you could have the immune system of a 40-year-old. You could be 40 years old with a lot of illnesses, and you could have the immune system of a 60-year-old. And we really do think that a lot of people who have a lot of comorbidities when they're young, 20, 30, 40, that they have more what we term progeria. They're aging more rapidly. So regardless of their biological birthday, chronological birthday age, they have an older biological age based on their comorbidities. So age is relative. I think it's more the biological age that's most important, and that we can tell by those factors that we discussed in the slide previously relating to mucosal immunity. Obesity and high BMI is really important. 73% of COVID-19 deaths were in overweight or obese people. That's striking. So that is a really big thing that we've got to be thinking about. So we have to understand, what are the root causes of obesity? What causes someone to gain weight regardless of what they're eating or regardless of how they're moving? I have many patients that I'm sure, and I honestly believe that obesity is actually an infectious disease. I actually believe that it's related to our biome, our microbiome. It's related to bugs that get into our system that basically can wreak havoc silently. It's related to a bunch of other metabolic syndrome pictures, but it really starts at baseline. And I don't think that it's one of those things that we should be ignoring anymore in our population, given that 3/4 of deaths related to COVID-19 were in overweight or obese people. So diabetes and hypertension are things that are going to be very challenging to change. There are root causes that will predispose somebody to having diabetes. Diabetes, hypertension, obesity, all of those things are included in metabolic syndrome. That is a particular diagnosis that we use in the medical community when people have all three of these things. When their weight is up, they have blood sugars that are higher, particularly type 2 diabetes, they have high blood pressure, and they're at risk for high cholesterol as well. With the male population, we're still learning a lot more about why they may be predisposed to getting sick with COVID and maybe having more fatality with COVID. But we have to continue to understand that a little bit more. But the immune system resilience is the one thing on this page that we can change. And if we change our immune system resilience, we will change all of the things about that. We will change our biological age. I wish I could change your chronological age, but I can't. But it's like when people take growth hormone because they want to be taller, we can change your biological age by making you healthier. If we create more resilience in the immune system, we will be able to manage your blood sugars better. We will be able to manage your blood pressure better. We can change your sex, male to female or female to male, but we can definitely change a lot of these other comorbidities. So the immune system resilience is really important. Now, our immune system foundation is laid by our genetics. So there's parts that we can't control, how they're laid down, but they'll also be influenced by early life exposures and the lifestyle that we're living previously and presently, the food that we're eating, the air that we're breathing, and all of those things relate to the exposome. So the exposome are all of the factors that you've been exposed to or an individual is exposed to in their lifetime. So it's a measure of all of those and how those exposures relate to your general health. Um, I'm just checking the time. Wow, I'm not going as fast as I want to. So those exposures will relate to what comorbidities you end up with, and that's really important to understand. So it needs to be studied more. There are greater than 150,000 different chemicals that are currently in use that get into our systems, our physical bodies, our body systems, and they get in there through the air and through the water, through the food that we eat, through the soil. So it's really important for us to continue to study this because it's going to be really important in terms of our immune system health and our immune resilience. And we need to be able to manage some of these factors. We have studied the human genome. In 2000, we discovered and deciphered the entire genome. We need to decipher a little bit more about the exposome, and there are lots of scientists that are working on that. We have to continue to characterize that and the body burden of that. So if you have a low body burden of some of these factors that affect your internal systems and your internal environment, then you're going to have significantly better immune resilience. If you have a high body burden of these factors that affect your internal system, then you're going to have lower immune resilience. So some of the factors, the biological factors that affect your internal environment will be your age, and that's your chronological age and how it is affected by biology and the things around you, your gene expression. Now our genes are fixed, but the way that they work, the way that they function, the way that they create our health is not fixed. Food talks to our genes, bugs talk to our genes, pollution talks to our genes. And when we're exposed to any of those things that are unhealthy for us, our genes function very differently. Our metabolism changes. There are a lot of foreign things in the environment. They're called xenobiotics. So those will affect your internal environment, your gut microflora, your gut microbiome, your inflammasome, the things that make you inflamed, your oxidative stress, all of those things will affect your internal environment. There are other external factors that affect your environment that you can change, that you can have, that you can manage your stress. You want to reduce your stress. Find a way, whether it's meditation, listening to music, singing, being with people on Zoom, whatever it is that you reduce your stress. It's really important because stress is a friend of the virus. Sleep, adequate sleep. We restore and regenerate during sleep. Growth hormone is secreted during sleep to clean up our systems, to clean up the mess of the day. So it's really important to sleep well and to sleep long enough, approximately 7 to 8 hours a night. Diet, the food that you eat and the additives in that food, really important. The type of physical activity that you do and the environmental threats and pollutants and infections that you're exposed to, like COVID-19. So the exposome is really, really important. Interestingly, in January 2020, Science magazine had an article about where chemistry meets biology, and it was all about the exposome and the chemical complexity of our world and how the chemicals that are in our environment are responsible for 9 million deaths per year. 16% of global deaths are attributed to air, water, soil pollution alone. That's pretty remarkable. So when we think about the exposome and immune resilience, we can ask the question, why do different people have varying infection, mild, moderate, severe, or no symptoms when they're exposed to COVID-19? So 90% will be asymptomatic. 9% will have a mild infection and recover in a 14 to 21 day window at home. And 1% will have a severe infection. And this variation in the response is due to your biological age, whether or not you have chronic disease, and your exposome. So it's really important to look at those factors. So I just outlined a few of them in this chart here, and this is a little bit busy, but if you look at the top, across the top, from left to right, people with no infection, people with mild infection, and people with severe infection to COVID-19. Let's stick in the left-hand column. If people have very mild exposomes, they don't have a lot of exposure to air pollution, they live in the country, they live a very calm, serene life, etc. They haven't had a lot of illness as a child, and so they have a mild exposome exposure. They have good and strong mucosal immunity and very little permeability or breach in the barriers between the outside and the inside world. So they have strong barriers, strong borders. They make great antibodies because they haven't had to do it over time to many diseases, and their natural killer cells are functioning well. They're going to get really mild infection. So even if you were at a Biogen conference, you should be happy that you didn't get the COVID-19 infection in a significant way, because all of these things in this category and other things, but I'm just keeping it simple here, basically kept you well. You are in this category with strong mucosal immunity, strong systemic immunity, good antibody production in the innate immune system and the adaptive immune system. So really important to understand that. The people who get mild infection may have had more exposures, more stressors throughout their life, more illness. Their microbiota may have been influenced by other things. They may not have perfect mucosal immunity. They may have had a lower secretory IgA or antibody in their saliva or their secretions that allowed COVID-19 through that day. They could have a little bit more of a delayed adaptive immune response or a delayed innate immune response, and their natural killer cells may be lower. In most people in my practice, we measure natural killer cells. So you can go back and look at your biomarkers and say, hey, how was my natural killer cell function? Normal would be about 12% to 15%. So, and all these people are, the people with severe infection all have compromise. So what we want to do is try to be in the no infection and the very least, the mild infection groups. So there is no magic bullet for treatment of COVID-19, and we know that. At this point in time, nothing on this list, not remdesivir, not a nutrient like zinc or vitamin C or vitamin D, or a monoclonal antibody like the ones that treat rheumatoid arthritis, or the one lenzilimab that was used at the Mayo Clinic and a small group of patients. Those patients got really sick. That these drugs were not preventative. They took a monoclonal antibody or remdesivir or any of the repurposed medications that we're using when they were sick. None of these medications can be used as a magic bullet preventatively, prophylactically, or as a treatment. There are some people who may get better, and they are the lucky ones. Now, the zinc and the vitamin C and the vitamin D are all used in hospitalized patients. And we also know, and if you reference in our guide, in our instructional guide for COVID-19 treatment, we have a lot of references as to how vitamin C, vitamin D, and zinc will work within the immune system to improve all of the things that we talked about, particularly your mucosal immunity, your natural killer cell function, and your antibody production. So zinc and vitamin C and vitamin D are your best bets, as we talked about previously, and it has been on my email for quite some time. A vaccine is going to be more than a year to develop. There's no way around it. COVID-19 is more like HIV, and we have been trying to get a vaccine for HIV for 30 years. 30 years. We talk about HIV in terms of viral load. When we talk about HIV in terms of the mucosal immunity, people who have low or poor mucosal immunity that are exposed to HIV virus, those are the people who end up with AIDS. There are other factors. Please don't just think that's the only factor. But that we know, that has been studied, that low mucosal immunity, low secretory IgA, you will be more likely to go from a virus exposure to having the syndrome of AIDS. It's similar with COVID. We are going to have viral exposure. The question is, how good is our immunity to prevent us from getting the disease COVID-19? So we can actively express our own antibodies, IgM and IgG, and improve our natural killer cells using the vitamin C, the zinc, the vitamin D are all probably the top three things that you can use to improve your immunity. That would be actively improving your immunity. Getting a vaccine would give you passive immunity via antibodies to prevent the infection from taking place. But in order to make that safe and effective and sustainable, that's going to be some time. And even if we do have a vaccine by January of 2021, it's not going to be for the masses. And we know that antibodies help because we have used people who have recovered, the convalescents, the people who have recovered, we've taken their blood and we've used it to confer and to give to sick people to confer passive immunity to people who have been sick, and they have done well with that. That may be a way that we can develop a medication or some type of treatment that we can use to treat patients who are sick with COVID. So passive, the vaccine will be more than a year to develop. Active, you'll be exposed to COVID. You'll be either asymptomatic or symptomatic, but you'll make your own antibodies and natural killer cells so that you don't end up with COVID-19 infection. So mucosal immunity we talked about. These are the antibodies that are secreted in the saliva. Systemic immunity are the antibodies that are floating around in your blood, in your serum. And they're similar, IgA and IgM, but there are more once it gets in your body. Of course, we have to have more antibodies. IgG, and there are multiple kinds of IgG, and also IgE. This is how we test. The key thing about this testing, this is the nasal swab test. And the nasal swab test is looking for virus. It's looking for virus that's actively in the system. And we can see that it's beginning to increase from day 1 through day 5 when you then become symptomatic. But look over here where this red arrow is. This is the incubation period. You've already been exposed. Day 1 is not exposure. Day 1 is when the virus begins to go up. You've been exposed, and the incubation period will last anywhere from 0 to 3 weeks. So it's really, really tricky. The symptoms may or may not come on, but it's important to understand that there's this whole period in here where people are asymptomatically transmitting virus to others. So the incubation period here, during day 5, around day 5, where you see this graph, this viral RNA peak, that's about the best time to be able to capture the RNA virus with a nasal swab. That's called an RT-PCR test. The RT-PCR test is looking for viral RNA. There are multiple different methods for looking for that, but generally they're swabs. They're generally throat cultures or swabs. I think the nasal swabs are best, but there's a lot of false negatives. So if it looks like COVID, smells like COVID, just believe it's COVID. Don't rely on a swab test, particularly if you get a negative swab and think it's not COVID. Treat it as if COVID, act as if it's COVID no matter what. We're not going to talk a lot about the symptoms because I'm hoping that most of you will not be symptomatic. If you are symptomatic, I invite you to call me. But here's serology testing. This is blood testing looking at antibodies. There are 2 types of antibodies. There may be more, but we're going to simplify this to 2 that are presently really being tested. The initial antibody, like the National Guard, the IgM, that means you're in the middle of the infection, and the IgG, which is the antibody that's going to protect you over the long haul. So the IgM is most abundant between day 5 and day 14. So we don't really want to be checking patients who have IgM if we're out in the clinic as opposed to in the hospital, because those patients are sick and they should be in quarantine. The IgG peaks between day 11 and should continue to be elevated throughout day 28 and beyond. I'll show another test about that. So there are multiple different antibody tests. There's a finger prick and there's serology. The finger prick you do at home. The finger prick testing for immunity is rapid. You get the test results back in 10 minutes. You can do it at home. It's a qualitative, tells you yes, no. You have antibodies or you do not have antibodies. It's dried blood, rapid results. If we have to send blood to a lab, the turnaround time is about 3 to 7 days. And that's blood that we draw in the office, send to the lab. And that often is qualitative, but can be quantitative as well. And I'll show you those. This is the sample that you do at home, the rapid collection. You put a little blood in a well, you add a little bit of reagent, and then you watch it pass, like a pregnancy test that many of you may have seen down here, and it will create these lines telling you whether or not you are likely to have antibodies. So there's always a control line, and the control is the furthest one always. So this is the C. The control line, it has to be positive in order for it to be a valid test. Then oftentimes there's either just an IgG or just an IgM. You'd have two cassettes if it were just an IgG or just an IgM, one cassette per antibody, or you might have both in the same cassette. IgM tells you that you have the infection actively. You should not be in a doctor's office. You should be quarantined. IgG tells you that you've already, the infection is on its way out, your body's immune, and you're likely going to be okay. There's very little evidence of reinfection, in a short-term phase, and we'll talk about that in a minute. But this is the ideal result for immunity: an IgG positive and a control positive. When you have your rapid test at home, if you've done those and you've gotten IgG without the control being positive, that's an invalid test. If you've only gotten the control positive with no band at IgG and no band at IgM, you are not immune. You do not have adequate antibodies to confer protection to you or to anybody else that you may expose yourself to. When you have both positive, you're in a transitional state. You're in the middle of the infection. You haven't completely handed it over to the IgG, which is the ideal result. The IgM is resolved and the IgG continues to be there. So that's really important to understand. This is the quantitative antibody testing. So these are 3 people that I've tested in my office. This is a person who had significant exposure, but I'm going to assume I don't have all of the lab values for this patient. She did not have any IgG. She did not have any IgM. She was in close contact in a very small square foot place with people, multiple people who had had the virus and were sick with the virus. She never got sick really with the virus, never major symptoms or, in terms of an infection. I would call her relatively asymptomatic, but I think that she has really good numbers in terms of who are the people who are going to get asymptomatic or mild infection. That's not what this patient wants to hear, but this is the reality of what we've tested. So we've done a couple of tests on this patient, both being negative. This patient here is a patient who, all of these patients are between age 50 and 60 years old. So this is a patient here who has an unknown exposure, no idea, had been wearing masks, had been staying away from people, had been relatively quarantined, but nonetheless got an exposure. So her number was 25. This is a number that should test positive with IgG and negative with IgM on a finger prick testing, the qualitative testing. This patient recovered at home. She had about a 14-day illness where mostly it was a lot of muscle pain, fevers, difficulty sleeping, anosmia, could not smell, could not taste. The smell continues to be gone, and it's been well over a month or probably almost 2 months for this patient since her illness. But she's doing quite well, and all she took at home was Tylenol. And she was quarantined alone throughout the entire illness with only people bringing her some food and other things. So you can survive this illness readily. This is another person who came in to do some antibody testing who had been sick along with her spouse earlier in the season, like late February, early March, and ended up with very high antibodies. This, in my mind, is a very positive thing because what we know about this infection is that it's likely to confer some immunity. So in terms of how do we get out into the world and, who is immunoprivileged, meaning their immune system is working for them to prevent them from getting infected, reinfected, and having problems, and to prevent them from infecting others. When we look at the positive antibody rates in different states, we can see that in the US, there's an average of 5%. There's not a lot of people who have immunoprivilege. In Boston, it's about 10%. So I've done several hundred tests in my office, and Mayor Walsh has done 800, and we're looking at these numbers. About 10% of people, that's not very many, have antibodies to COVID-19. In Miami, it's 6%, and of course in New York, they have the most because they have the most people per square foot. They have the highest density. This is a study that we talked a lot about in the instructional guide for COVID that we wrote, Dr. Akey and I, looking at SARS back in 2002, which is a cousin of COVID-19. And this was a study that actually was cited improperly in JAMA this week or last week, just recently. I read the study multiple times, and basically what the study showed was that they looked at 176 patients who had been sick with SARS back in 2002. And they followed these patients from the time of illness at 6 months, 1 year, 2 years, and 3 years with serum testing, with blood testing to see if they continue to have antibodies. They didn't have a 176 patients that came back for the follow-up for every single follow-up, 6 months, 1 year, 2 year, 3 year. They only had 18 that did every follow-up, but they had some follow-up for each of the patients. And basically what they found was the duration of antibody responses after SARS was 100% going out to 2 years, and just maybe 89% here at 2 years. And as they went out to 3 years, it was 55%. That's pretty good. So if SARS from 2002 and COVID-19, these pandemics that came about, that surprised us, can our sisters or cousins or whatever in the same family, and we get an IgG response like that, it is extremely hopeful that COVID-19 will be able to generate an antibody response that will last at least 2 years, and that will get us through the next few seasons, because we are going to have an increase, given that we only have 5% in the United States positive antibodies. This is going to continue to roll out over time. It's really important to think about how do we get back into the community, because the our mental well-being is really important. And now with the weather being being warmer, we do know that we have a little bit of a respite. And between now and November, probably, we are going to have a respite from COVID-19. It doesn't mean it's going to be gone, but the amount of infections, because we can be outside and improve aeration and spread out a little bit more and not be as exposed to high viral loads, then we will be able to, basically enjoy ourselves until we have to be indoors again here. So a vaccine is going to be a long time to create. So I really think that we want to be thinking about how can we improve our immune system. So the basics for immune support, and there's way more. We have a variety of tiers that we've identified, on the basis of priority in the instructional guide. But for sure, zinc at 30 to 60 milligrams per day, vitamin C at 500 to 2,000 milligrams per day, vitamin D at 2,000 to 4,000 units per day, omega-3 at 2,500 milligrams per day minimum, and colostrum are some of the really important things that can improve the immune system, whether it's the mucosal immunity or the systemic immunity. So if you don't have time to be sick, then please make time to be well. This is the cover of the book, Kick COVID-19 to the Curb. It's an instructional guide. I'm most proud of it being highly well referenced. And in the ebook form, you can just click on the reference and see the data for yourself. We picked the most recent data and the best data that exists, and it's readily available in this instructional guide. I'm going to bring Dr. Akey on in a minute, but this is a foreword by a wonderful, well-known, world-renowned immunologist, Dr. Yehuda Schoenfeld. He is the father of immunology. He published the 20-pound textbook, Mosaic of Autoimmunity, and he did the foreword to the book, which we're really proud of. Talked about this being an unprecedented phenomenon, and that really just trying to keep up with the details of this virus in a very quick way has been really challenging, but that the instructional guide provides a lot of information around that, and we'll continue to update that. So let me transfer this to Noelle so that she's the host, and she can bring on Dr. Akey, and then she will read the questions to us, and we will continue to answer your questions.
Okay, so I'm now the host. Let me see if I get Dr. Akey. Dr. Akey, we should be able to hear you now.
Yeah, it's still saying unable to start video.
Oh,
That's a great job teaching, Dr. Kathleen. Such a privilege to teach with you. Your
Oh,
patients are very blessed.
Dr. Akey, in the bottom left-hand corner of your screen next to the mute, do you see where it says start and stop video?
Yes, it's just not letting me start it.
Oh, hmm.
You can't start your video because the host has stopped it. We can talk anyway, Kathleen.
Yeah, so I think what we can do is, Noelle, let's just give Dr. Akey a minute to say whatever she'd like to say and add some insight for the book, for the instructional guide, the book, and then maybe you can start with some questions for us. But I know we're limited in time and I want to be very respectful. I'm sorry I took so long, guys.
You did great. So I don't know if you could give me the video just for a minute just to explain the book, because I'm carrying a galley copy. But so anyway, I'm Dr. Akey, and I'm just really privileged to join Treat Wellness and Dr. Kathleen's community. I write in the book how after 30 years in medicine, I finally found somebody who I could banter with and refine ideas, and I'm really happy to be a guest in her Treat Wellness practice in Boston. We've been very busy taking care of patients and then putting it in a reference guide, instructional guide. Our book launch week actually starts this Friday, the 22nd, and it's going to go for a whole week until the 29th. And we have a hard launch date next Wednesday. So Dr. Kathleen, we could actually launch the national and international book launch next Wednesday at your time slot if you'd like, from 7 to 8. But basically, in Florida, we haven't had nearly the same amount of penetration as you've had in Boston. I've been doing what's called drive-up evaluations outside my practice for over 2 months now, and have managed and diagnosed 4 of my patients out of 6,000. My county in Alachua County is not nearly as large as Boston, but our incidence is really low still. So we're not even close to obtaining herd immunity. And that's actually a concern for my patients because I have a lot of seniors as well. So I've been very busy with our team trying to protect especially those vulnerable seniors.
So yeah, I mean, I think we have really different incidences and prevalence around the country, and everyone's going to see it because 100% of us are going to be exposed to it. But I think the big principles of being well are really important. We've been working, Dr. Akey and I, and this team that the Noelle and Kaylin and all of the people who are on here. There are some others that aren't being named, but Reshma, et cetera. They're all been amazing, working around the clock to try to bring all of this data together. Can we answer any questions for you? Noelle, are there any questions?
Yes, we have a lot of questions. A few of them you'll answer during your presentation, but I'll just start at the top. The first one is, if you have to fly on an airplane, what are the risks and what is the best protocol for when you return home, how you can best prepare your immune system to fly?
Well, I think being on a plane, again, speaking about that, being indoors, and then having, if there are a lot of people on this plane, you have got to wear a mask. You've got to bring, really good hand sanitizer and wipes to wipe everything down. If you're sitting next to somebody that's coughing or sneezing, game over. I'm not sure what to say. I would get off and I would walk off the plane. Flights are cheap right now. I would try, if we're going to fly, I would get on the plane and I would think about being on the plane. I would assess the situation around me. If it were a really overcrowded plane, I think I'd get off. I would ask the people around me, have you been sick? Because people have been getting on planes and not telling anybody that they're sick until they get off the plane. So it's really risky. But if you boost your immunity beforehand, and if you look at your biomarkers, your natural killer cell function, your secretory IgA, your antibodies, et cetera, and you know all of these biomarkers beforehand, then you're going to do a better job at reducing your risk and being in that no infection category, or the mild infection category at least. And if you're in the mild infection category, it's not the worst thing in the world if you need to get on that plane and travel. But I really think that you're putting yourself at risk. So if you don't have any of the comorbidities that we talked about, and you think that you haven't had a lot of bad exposures over your life or challenges over your life, then you're probably going to be okay as long as you aren't sitting next to somebody coughing or sneezing.
Okay, so the next question is, do you want us to get the vaccine when it comes out?
I love my patients. Um, I do not think the vaccine is a solution, and I actually am. I'm going to be really curious to see what comes up for a vaccine, because I know when you think about HIV, a virus, and you think about SARS-CoV-2, a virus that causes COVID-19, the question is going to be, why haven't we been able to create a virus for something that needs a cocktail of therapies as well, because it has multiple mechanisms of invasion into the body. We'll have to see what the virus looks like, and we'll have to look at that individual and be sure if that individual should have that virus. I would take it on an individual by individual basis. But if you think you're in that no infection category from that chart I showed, and I'll go back to that chart, I think that that would be the most important thing. So it would be, with my patients, a case by case situation.
Would vitamin C infusions be a treatment to consider if you were to get COVID?
I do vitamin C infusions. I know Dr. Akes does vitamin C infusions, because if we see anybody or we go to the supermarket, is not a high risk place, by the way. Um, so really, it's parties and indoor parties, some outdoor parties. If you're all raucous and you're having a grand old time, that could be a party, and you're all singing Danny Boy. If you're Irish, then that's high risk. But generally speaking, being outdoors, hanging around, quiet party, 6 to 10 people, probably not going to get infected if it's a short period of time. But I do think that we just have to really look at the patient one by one and think about the exposure.
So would you advise like screening the guests if you were to have a dinner party, or if you were to have like your kids had their friends over? Should we be asking our guests to wear masks? And if we're doing a outside party, should they be wearing masks as well?
Small party, 6 people, 10 people that you know really, really well, and you trust them to tell you the truth about their exposures, that they haven't been out partying, that, night clubbing, then sure, they don't have to wear masks. But I think that if you don't know the people really, really well, and you don't trust that you're getting the true story because you don't know them, then I would wear masks. What about you, Dr. Ike? I would absolutely wear masks. I think no kissing, no hugging, no handshaking, masks, washing your hands regularly are the basics that we can do.
Well, I've trained my population here in Gainesville, Florida, to use masks when it goes in reference to like medical masks and operating room masks. So we talk about facial coverings, and I think that facial coverings are a must still, especially when you're within 6 feet, but especially when there's wind. I mean, if you have a party outside and there's wind, I think it's we're starting to move out and starting to gather. I still think it's a little risky with the airborne droplet, etc. One thing I've been advising my patient population is to get aromatherapy vaporizers if you're hanging out with your family members that you haven't seen. I have an 81-year-old mother, and so when I'm on the porch and she's 6 feet away, I'm actually putting a hydrogen peroxide into a vaporizer with my lavender. So it kind of cleans the air.
Next question.
Okay, is it safe to get my hair done, or should I skip that for a later date?
Well, I would say, if you go into the salon, salons can be very boisterous. That's one of my favorite things about a salon. But if it's relatively quiet and people aren't, talking a lot and boisterously and coughing, and you're at least 6 feet apart every other station, and people are wearing masks, and you are well in this no to mild infection category, I think you can go out. I do.
Okay,
Just think
and
be cautious.
how long does it take doing all the right things to build from a weak to a strong immune system? What have you seen with patients in terms of range of time?
Well, I think, if you have a weak immune system, you can renovate a house or you can build a house. When we start from scratch, they go up a lot faster. When we build a baby, it takes 9 months. So when we're renovating our aged immune systems, then it takes a little bit longer. I think any change is better than no change. Anything that we can do to improve our immunity. And if you want to improve the mucosal immunity that's outside the body, you can specifically address that. So you can begin wherever you need to begin. I like to use data to drive my beginnings, how I'm going to construct a program to build a foundation of immunity in somebody who's challenged. but we can always do it. I believe 100%, and I've had market success over 13 years at building mucosal immunity and barriers.
Okay. And piggybacking, going back to Dr. Akey's question, is it safe to inhale hydrogen peroxide?
Well, I am not going to promote that presently, but I know that Dr. Akey has had some experience with that. So I've had experience with it. I'm not going to promote it personally, but she can talk about her positive experience with it.
Yeah, so I was talking about using hydrogen peroxide diluted in a vaporizer for airspace, not inhaled directly. So basically, you could take 1 teaspoon. You just buy a $10 or $20 vaporizer for aromatherapy on Amazon, and when you're gathered with people, still stay 6 feet apart, but you normally add like lavender and different types of aromatherapies in there. Just drop a teaspoon of hydrogen peroxide in there, and so that when you're gathering, you have some cleanliness to the air.
I think one of the key things about that question is hydrogen peroxide. We wouldn't promote that as a treatment, and we wouldn't promote it as a prophylaxis as either at this point in terms of inhaling it or swallowing it or putting it in your system in any way. Yeah, I don't think that we would be. I think you should have a personal conversation with your doctor if that's something you're considering.
Okay. And would you say that any labs to test antibodies are more reliable than one another? Like, is Quest more reliable? And what is the false negative percentage? And how do we get rapid tests?
Okay, so really, really important. So all of the labs vary in all of the different kinds of labs. So if we just let's take the antibody testing only, because the acute testing will not be done by me. It may be done by Dr. Akey. She has a conventional practice as well. I don't have a conventional practice, and I won't do acute testing. So the antibody testing will be done 14 days from exposure or 14 days from symptoms, from symptom initiation, and ideally when symptoms have been resolved, because that's going to be the best way. The lab testing at Quest presently for antibodies is the same as the finger prick testing. So presently, from the lab people that I know, the medical people and the PhD people that work in labs and work at Quest, the testing at Quest presently is the same as the finger prick testing that I have had and Dr. Akey has. So those are available. You can email the office. The serology testing would be later than doing the finger prick testing. And if the finger prick testing is negative, it has very good sensitivity and specificity, far better than the nasal swab testing. Is it perfect? 100% no. The nasal swab testing will miss 3 to 4 out of 10 people. They will be negative when they're positive. The antibody testing will miss people who don't have adequate antibodies. So when the numbers that you saw that I measured, the 0, the woman who was green, the person who was red at 25, and the person who was red in the 60s, you really have to have at least a 25 or higher, I think, based upon the data that I've seen, as a number of antibodies in order to get the finger prick testing positive. So it's tricky, but I think the antibody testing is pretty good. I would say that I can't really speak to the false negative rate, because there's a lot of math that's involved, and the math that's involved depends upon the prevalence. So the higher the prevalence in the community, the better the testing results are. So that's a little tricky. It's counterintuitive information, so I really don't want to get into that. But I think that the antibody testing is pretty good.
Can I add to that, Dr. Kathleen?
Please.
So, and always remember that there's a 5 to 10% of the population that don't make antibodies. And so it's not for that population that even if they got exposed, they wouldn't make antibodies.
I would imagine, however, that the 5%, it's about 5% who don't make antibodies, that those are people who have other things going on. Because if you're not making antibodies to COVID, there's something wrong in your body systemically. So I would say that you would probably need a doctor for other reasons. Next question.
So can you comment on your opinions about schools resuming in the fall and the safety of it? universities, sporting events, and then also to go off of that, you could also comment on surgeries in the surgery, whether elective or not.
Yes. So I think it's really a problem if we go back to indoor sports events, enclosed environments, poor air circulation, increased density of people, prolonged period of time. Sports events take 3 hours. That's how they make their money. A lot of people up and screaming and drinking and shouting and becoming emotional. It's a really risky situation presently. I personally would not go into a sporting event indoors. No way. It's really, really, really not responsible. Um, so they are a hotspot for transmission. Conferences, medical conferences, other conferences, hotspot for transmission for the same reasons I just mentioned. Um, Funerals are a hotspot for transmission. Birthday parties that have a lot of people are a hotspot for transmission. If you're in a place with really good airflow, low density of people, then it's going to be okay. Schools. I have an opinion about schools. Obviously it's not dogma. I say follow the recommendations. I think Massachusetts has been unbelievably amazing with respect to recommendations. But for school, I think that the schools should go back, wear masks, be clean, take temperatures as they're recommending, I think it's at the CDC, and then probably start earlier in August and end sometime in November, and take a long break during the period when this is going to be transmitted again, where the bumps are going to go up for COVID transmission again. So I think that we really need to be thinking about how we do school, and I think we can do it. It's just about how we do it and when we do it. And that's a conversation that will probably evolve as we learn more and more about the virus.
Okay, and then the next questions, there's quite a few that have to do about the different symptoms of COVID right now, and maybe the long-term health complications. So a person talked about metallic taste in the mouth
Mm-hmm.
in terms of the virus presence
Mm-hmm.
and contagiousness, as well as COVID toes and clotting syndrome.
Yeah. So metallic taste can be a symptom of COVID. It can be a symptom of other things as well. So if you have metallic taste, it doesn't mean you have COVID if that's the only symptom. It's the constellation of symptoms that you have to look at. But if anything looks like COVID, smells like COVID, sounds like COVID, again, remember I said it act as if it's COVID, and protect yourself and others by wearing masks, staying quarantined, etc. I think in terms of COVID toes and the clotting, so the unique symptoms of COVID have to do with the overactivation of the immune system, which ultimately ends in that cytokine storm. And that's often what happens. Cytokine storms happen in autoimmunity and autoinflammatory situations and conditions. So people who have big problems with autoinflammation, or meaning inflammation gets revved up, or they have an autoimmune condition, those are the people to think about from that perspective. With respect to clotting, clotting is a really big issue with COVID. So anybody who has a genomic propensity, a factor 5, a factor 2, a protein C, a protein S, and many of these things are things that we've measured in patients in my practice. So you would know if you were one of the ones that were more likely, based on a few genomics anyway, to have a clotting diathesis. I mean, it's important that omega-3s are anticoagulants of sorts. So that's why they're on the list for me. Aspirin is another mechanism. I don't think aspirin's a strong mechanism. I think omega-3 will be the best mechanism for clotting. But if you have a clotting diathesis, it's really important, if you're my patient, to have a conversation with me so that we have something prepared in the event that you get infected. And I want it in your fridge so that by the time you get infected, you're ready to start a particular medication that is an anti-clotting medication. And I really believe that we have to be evaluating people for this clotting diathesis. So, there are 3 components: the hypercoagulable clotting state, the immune response, the overactive immune response, and the inflammatory response, the oxidative stress. We've got to treat all 3 of those in people who end up sick with COVID, mostly with severe infection. Mild infection usually get through it. COVID toes means that there's something really serious going on, and that warrants a very significant in-depth evaluation.
All right. And then how do you feel about if you're at a small party, 6 to 10 guests, and just guests using your bathrooms in your house? Is that safe?
Well, we don't know of any fecal oral transmission or transmission, but again, it can sit on surfaces. So the surfaces need to be clean. So I would have a conversation with your guests about how you're going to clean the surfaces if somebody goes into the bathroom. But you should obviously have some, sanitizer in the bathroom for cleaning the surfaces that the person touched. If the person could go in and not touch a lot of surfaces and just go in, use the bathroom, wash their hands, keep their mask on, leave, and then do a little bit of disinfecting, that would be ideal. That's going to be more tricky in restaurants.
Okay. And what are your thoughts on modified citrus pectin to address the cytokine storm?
Oh gosh, by the time you get a cytokine storm, forget about modified citrus pectin. It's too late. I love modified citrus pectin. It's wonderful, but not to address a cytokine storm. If you get to the point of a cytokine storm, you're in a hospital and it's not up to you anymore what you're going to be taking. It's going to be up to the clinicians what they give you. So if you can take that in advance as a prophylactic immune support, I love it. Absolutely.
All right. And then if you return from a plane trip, what is the proper approach to quarantining?
Well, I think 14 days minimum. I think that you should quarantine 14 days, work from home, ideally not go to the supermarket, have other people drop off the food, because I think if you're on a crowded plane, the likelihood of having an exposure is very high. Whether or not you become infected or have symptoms from that infection based on that exposure has to do with, again, your exposome, your immunity, etc. So that's really different. But I think you need to do 14 days.
All right. I think you answered all of the questions here that they had. And so you're all done.
Okay, thank you so much, everybody. Thank you, thank you, thank you. We're certainly available. Please email me. You know my email, treatwellnessmail@gmail.com. Call our office, 617-630-2882 if you have any questions. If you're new, if you're a friend of a patient, then we're happy to help you in any way. Any simple way, any more complex way that you might need, but just be in touch with us. Dr. Akey and I, she's in Florida, so if you're near to Florida and you're on this call, please go to Gainesville and see Dr. Akey. We will do Zoom consults with anybody. We really want to help. We want to make the population healthier. That is our passion. That is our raison d'etre, and that is the legacy that we want to leave. Anything
Yeah,
else?
thank you so much for having me, Dr. Kathleen. It's a pleasure to be in your community. And Dr. Kathleen came to mine last Friday, and they love Dr. Kathleen. So we'll be rolling out together with this book launch next week as the Fire 'em Up Doctors. So save next Wednesday night, if that works for you, Dr. Kathleen, and we'll get this rolling. So
Okay.
thank you for having me.
Thank you, Dr. Akey. Thank you. Thank you all. And please get out and enjoy the fresh air and keep your social distancing. Bring a mask with you in case you need it. You don't really need it unless you're in contact with somebody for a little bit of time, like 5 or 10 or 15 minutes if you're stopping to talk to them on a run or a walk and you're closer than 6 feet. So definitely just get out there and enjoy the fresh air.
And then everyone asking, we do have a Facebook page where the recording will be posted, and you can continue to ask questions on there. And at the rest of the town halls, we can ask those questions as well.
You're the best, Noelle. Thank you for remembering that.
Thanks, Noel.
Thank you all. Have a great night.